Retinal detachments classification, there are three types: rhegmatogenous, tractional, and exudative. So out of these three, rhegmatogenous retinal detachment is the most common type of retinal detachment. And some of the predisposing factors for the rhegmatogenous retinal detachment is the age factor, increasing age, 50, 60 years of age, myopia, or condition like aphakia and pseudophakia, and any retinal degenerations like lattice degenerations following trauma and following posterior vitreous detachment. So these all the risk factors will cause dynamic vitreoretinal tractions, and that will lead to retinal breaks. Whenever following break, the degenerating fluid of the vitreous will enter through the break and collect as subretinal fluid between the sensory and the RPE layers. Following the pathology and risk factors, the symptoms of the rhegmatogenous retinal detachment are floaters and vision loss, photopsia. Vision loss is usually sudden, painless vision loss. And the signs is tobacco dusting appearance may be present in the anterior vitreous, that is called as Schaffer sign. And whenever there is posterior vitreous detachment is a risk factor, so it is almost always present, and retinal breaks will be there. Commonly, the retinal breaks are present only in the rhegmatogenous retinal detachment. Configuration of detached retina is convex. It is freely mobile. The detached retina is freely mobile. And in long standing cases, there could be subretinal demarcation lines or any secondary intraretinal cyst in very old retinal detachments. And common complications of rhegmatogenous retinal detachment is proliferative vitreoretinopathy. Apart from this, in rhegmatogenous retinal detachment, on observing with the distant direct ophthalmoscopy, there will be grayish reflex, absence of red reflex, and Marcus gun pupil sign will be positive. And the type of tear or retinal break seen here mostly is horseshoe shaped, or it also could be giant tear or anterior retinal dialysis, or it could be retinal hole. Most common quadrant where the retinal tear can be seen is upper temporal or supratemporal quadrant. And the treatment could be, yeah, sealing of the retinal break with cryocoagulation or photocoagulation. Then you have to also go for drainage of subretinal fluid, and maintenance of appropriate apposition of the detached neurosensory retina with the retinal pigment epithelium. That can be done by scleral buckling either with external tamponade or internal tamponade. External tamponade is scleral buckling, internal tamponade is with gases like SF6 and C3F8. Whereas in the tractional retinal detachment, there will be no retinal break, and also there will be no floaters or photopsia complaint, and vision loss is basically slow. The main pathology is formation of vitreoretinal traction bands that could be following post trauma, post hemorrhage, and most common is proliferative diabetic retinopathy, retinopathy of prematurity, sickle cell retinopathy, and Eales disease. And the configuration created here will be concave in nature, and all other signs seen in rhegmatogenous retinal detachment are absent. No tobacco dusting appearance, not predisposition of posterior vitreous detachments, usually no retinal breaks. Mobility of the detached retina is decreased actually, shifting fluid is absent. Exudative retinal detachment, it occurs because of retina being pushed by either fluid or neoplasm beneath it. It could be because of any inflammatory or vascular lesions. And like example, systemic causes like toxemia of pregnancy or renal hypertension, or any ocular causes. It could be congenital inflammatory vascular neoplasm, or sudden hypotony following any trauma or intraoperative operations, choroidal neovascularization, uveal effusion syndrome. All these inflammatory and vascular causes or neoplastic causes will cause fluid accumulation beneath the retina. And there will be no photopsia floaters or any retinal breaks, no tobacco dusting sign, no predisposed posterior vitreous detachment, retinal breaks are absent. Configuration is again convex here. shifting fluid sign is pathognomic and is present. And in rugmatogenous retinal detachment, we're doing the treatment was like closing the retinal break with photocoagulation or cryocoagulation, followed by drainage of subretinal fluid and scleral buckling or pneumatic retinopexy. In tractional retinal detachment, that is because of vitreoretinal traction bands. So by pars plana vitrectomy, we have to remove all those and then internal tamponade is applied. In exudative retinal detachment, if it is because of any exudate or transudate, it undergoes itself resolution. But if it is because of any neoplasm, then we have to remove the enucleation must be done.